Welcome everybody to the webinar VEITH meets EVTM. We are going to start now the meeting. We would like to welcome. It's broadcast by a studio here in Örebro, Sweden, and I will leave the words to Professor VEITH and Professor Dubos in the US. So we will unmute now and go forward with this.
Can you hear me?
Yes, we can hear you.
Okay. I'm Frank Weiss, and my co-moderator is Joe DeBoff, and it's a real pleasure to have VEITH Symposium join forces with EVTM to have this exciting webinar on endovascular resuscitation and trauma management. Now, everybody knows that we're living in trying times with this darn virus, and one of the penalties of the virus is that we cannot have live medical meetings. We know there's no substitute for live meetings, but in our inability to have them, we have an obligation to maintain our primary mission of educating vascular surgeons and other vascular specialists, and really all those who deal with vascular trauma, by putting on webinars like this one, which give the state of the art as of this moment. So it's a real pleasure to be participating with EVTM in this webinar, and I look forward to some very exciting talks and cases. And Joe DeBoss will now say a few words of introduction, and then we'll introduce the first speaker. So everybody, welcome. Pleasure to be here.
Thank you, Dr. VEITH, and I'd like to give a special thanks to Tal Horde, David McGreevy, Todd Rasmussen, Dr. Asher, and yourself for organizing this very important event. We're very much have worked very hard to put together in this 2-week block over this presentation over those 2 weeks in 2 separate blocks, really a wonderful faculty that's going to be able to really talk about how this marriage of endovascular resuscitation and trauma management and many of the principles that you've been speaking about for decades through the VEITH Symposium and your other efforts. With that, I'm going to jump straight into my talk, which is, let me share my screen here, sorry. You need to enable my screen sharing, and while we're waiting on that, if I can get my screen sharing enabled, I'll go ahead and get started with my talk.
Why don't you just give the title, Joe?
You're enabling? Okay.
There we go.
There you have it. So what I've been tasked to talk about is vascular injury care, and the synopsis is essentially who, what, and how. What vascular providers, who has the time, who among this group of experts in the field of trauma, vascular surgery, interventional radiology has the time. I don't have any disclosures here for this. What excites me about this stage of life in the care of vascular injury is that we are really counting an evolution across the full spectrum of care, from diagnosis to damage control, definitive management opportunities, and even the very unique environments in the form of a hybrid operating environments that we're now employing for these patients. Now, a lot of what I'm going to talk about, we outlined very recently last month in the Annals of Surgery. This is Beyond the Crossroads, an article that really has garnered quite a bit of discussion on both sides of the fence in the trauma and the vascular realm. And I would encourage all of you, if you really want a more detailed and nuanced view of what we're kind of talking about, please do review this. But we're really in an era of converging needs for patients and diverging skill sets in some ways. So the patients now have this plethora of new endovascular technologies that can be applied, but those capabilities need to converge on the patient, even as the skill sets and the disciplines to some degree diverge. And this involves a team effort-based group from vascular surgeons, trauma surgeons, interventional radiologists. So this raises the question, who should be the champion of vascular injury? Who wants this role? Who has the time to fulfill it? And who's best suited with the required skill sets? Verboa represents one spectrum of this technology. It is certainly a technology that has been employed by acute care surgeons. And what we've learned in a growing experience, both through Tal Hor's registry and the aorta registry here in the United States, as we continue to gather experience, is that trauma surgeons can be effectively trained to employ this simple endovascular technology. It may be superior to traditional trauma modalities for some patients, that the technology continues to improve and improve the complication rates, and that those complications can be overcome with training and effective partnership because they're consistent, predictable, and avoidable. But some complications are going to occur. This is an example of a balloon that migrated south and was deployed in the iliac artery. And through an effective partnership between trauma and vascular surgeons, this was identified and managed very quickly and effectively with an iliac covered stent graft. But there are also a host of vascular complications that can occur, not only with Reboa, but across the full spectrum of trauma care. And we need to work effectively as teams to manage these complications. And this requires skill sets across both ends of the spectrum. We also bring to the fight in the current era new tools for vascular diagnosis that are not been traditionally employed in the form of ultrasound, non-invasive technologies, IVUS, that really are coming to the forefront of trauma care. We now have, even in addition to Reboa, we have a host of new technologies and evolving technologies that can be employed for emergent care. When you talk about damage control, Reboa represents a fundamental balloon that can be utilized, but really if the basic tenets of vascular trauma care are proximal control, distal control, and fix what's in the middle, in many instances, particularly in anatomically challenging sites, proximal balloon occlusion can serve very nicely to augment patient care. And embolization is a skill set that's been well known within the trauma community for some time, but there's a growing number of devices and materials and even skill sets of providers that can employ this effectively. I was not trained in my vascular fellowship to embolize the liver routinely, but I do it now. We see this in a patient here who had a severe grade liver injury. You see the extravasation and the subsequent selective embolization of that bleeding vessel. And this was all done in a combined effort between trauma and vascular surgeons. And I think in many ways at certain institutions, it's going to be the way of the future. And of course, for definitive management with the advent of stent grafts, it's changed the way we take care of many of these injuries. Blunt thoracic aortic injuries are now largely treated almost exclusively with TEVAR for most patients. And you see other anatomically challenging areas, including the axillosubclavian injuries, which 4 years ago, about 11% of those were managed with endovascular stent graft technologies. And our most recent evaluation of the Prove It registry suggested as many as 40% of these are now managed in that fashion. But we also have to balance this with the understanding that the majority of trauma continues to require open skills. And we have to struggle with, as both vascular and trauma surgeons, how do we maintain the acquisition and the maintenance of those open skills in the face of these evolving endovascular technologies for utilization? There are lots of reasons and contributing factors for the loss of open skills. Endovascular capabilities in and of themselves contribute. Changes in training paradigms, both on the trauma and the vascular side, and even the proliferation of trauma centers, which contributes to a dilution of experience for these patients, also contributes. So what should we do to contribute to changing this and combat these trends? We need to engage in a multidisciplinary fashion with, I think, vascular surgeons as true champions in this regard, in improving training across disciplines for both our trauma and vascular trainees. We need to identify champions of vascular trauma at our institutions. And we need to understand that trauma care in the modern context of these evolving endovascular technologies really continues to be a team effort, and we need to work actively together across disciplinary lines to optimize care. So my punchline is, whether you're an interventional radiologist, trauma, or surgeon, or a vascular surgeon, when it comes to vascular injury, lead, follow, or get out of the way. And I think that we can all do that together. This battle line can have multiple leaders, and each institution needs to identify those. So with that, I'm going to now subsequently pave the way and transition after I get out of my stop of my share screen. And our first session here will be the titled Endovascular Solutions for Vascular Trauma. We'll have several 5-minute case presentations and very rapid discussions. We're going to stick very tightly to this timeline. And our first speaker is Dr. Ravi Vajani, also a kindred spirit of mine who's dual trained in vascular and trauma surgery, and is a vascular leader, thought leader at Emory University in Atlanta, Georgia. With that, Ravi, I will turn the floor to you.
Morning, everybody. Thanks, Joe. Really want to thank Dr. VEITH and the remainder of the leadership. It's great to see all of you. As always, I'm very angry at you for putting me right after an amazing talk by Dr. DeBose, which seems to be my lot in life. I'm going to start with some very basic overview, and then we'll transition to some case presentations by colleagues around the country. I hope that you can all see my slides.
Yep.
Yes.
Yep.
Great, thank you. Let me actually start the slideshow. So, do you have my slideshow, or do you just have the PowerPoint up?
We see this. We have to change to the show.
Yeah,
At
I'm
the
trying
top,
to do
you go to
something.
Change the
slideshow.
screen. Yeah. Now.
Better?
Yep.
Yep.
But someone is changing it for me. There we go. So here to talk about some basic things about endovascular options for trauma. I have no pertinent disclosures, as you can see here. As Joe mentioned, we've seen a lot of change around this, and it's curious to me how this happened. I can show this CAT scan of a 35-year-old male following motorcycle collision, and I think in 2020, there's very little discussion about how this patient is going to be treated, quite honestly. I cannot remember the last time a patient in our hospital underwent open repair of aortic transection. I imagine many of your experience is the same. And the reality is every single person in this virtual room will look at the two pictures, and if it was their loved one, they would want the top picture done. They would want a TVAR done for something like this. I think very few people would want the paraplegia risk of undergoing open aortic reconstruction after trauma. Similarly, I can show you this picture, and while we may have some disagreements about a stent graft versus open repair, I think most of us would gravitate towards open repair for a pretty straightforward above-knee popliteal injury, particularly after something like a gunshot wound. So why? Why do we get to this point where some injuries have clearly gravitated towards endovascular therapy and others have clearly continue to be managed with open? And I think it's helpful to think about how do we do things. This is the good old way, right? This is the way many of us were taught. You make an incision. You look at what you're trying to fix. You get control of it. You do something to it, whether it be putting stitches in it, replacing it with a graft, and then you close up. But the reality is we also do it this way, and it's much fancier. We put a wire in something. We take pictures. We identify what's wrong, and then we use balloons or stents or coils to stop the bleeding, and then we take the sheath out. And this is how all the kids do it these days. Where are the differences? The differences are really in exposure in my mind. Exposure is a big part of it. Vessels that we can easily get to with open surgery remain very preferable to treat trauma in open surgical manners. Similarly, the other big difference is the idea of clamping and the idea of interrupting blood flow to the end organ, which has, as we can imagine, deleterious effects downstream. And those are sort of the wheelhouse areas where endovascular therapy has clear preferential benefit. So no exposure needed, no need to clamp the vessels, and obviously surrounding structures remain free from risk. Where is operative exposure easy? The neck, the carotid, intraperitoneal vessels, arm vessels, common femoral, SFA, and popliteal. And in these areas, it remains that there's minimal advantage of endovascular therapy when compared with open. I think very few people would disagree with that. But where is operative exposure relatively difficult? Inside the skull, at the thoracic outlet, in the back of your chest, in the back of your belly. And in these areas, there's obvious increased advantage of endovascular therapy when compared to open surgery. And that's what we've seen, right? We've all known that the arch stent grafting of axial subclavian injuries has become, as Joe mentioned, almost standard of care. I showed you that CAT scan in the beginning, and very few people would want open surgical therapy of their descending thoracic aorta when compared with a TVAR. Blunt celiac, blunt SMA, blunt renal injuries, these are better managed with endovascular techniques, but pelvic embolization, right? Open ligation of pelvic vessels is not something that anyone wants to partake in. And we've seen, because of this difference in difficulty, if you will, of operative exposure, gravitation towards certain areas which are obviously better managed with endovascular means. Once we're there, what do we do about it? Joe has mentioned some of these things, but balloon occlusion is the first endovascular case that any of us ever did for trauma. Whether that be putting a balloon up in the subclavian in order to facilitate a thoracic outlet exposure, or for resuscitative reasons like we see with the Reboa catheter. Coil embolization for vessel sacrifice, and stent graft reconstruction for vessel reconstruction for both thrombotic and hemorrhagic pathologies. These things are part of our armamentarium, and a large part of it has to do with what's easy to get to, what's not easy to get to. But there's pitfalls. The reality is, as Joe alluded to, it requires specialized training and skills, and those skills don't necessarily line up with how we train people in the American healthcare system. A trauma surgeon is best suited to understand the overall physiology of how sick someone is, but they don't generally get the background in wiring catheter skills to accomplish many of these things. I would take the point to highlight that most of it is pretty easy to figure out. Most of what we do is pretty basic plumbing. It does require particularly specialized training and skills, though, when things go wrong. That Reboa picture that Joe showed where the iliac artery ruptured is a great example, right? Putting a Reboa in is something that every trauma surgeon should be very comfortable with doing. But when there's that complication, that's where the team effort really comes to the front. And I would also point out that these endovascular solutions do not address three things, and they're important to always keep in mind when trying to figure out the best way forward. They don't address the hematoma. They don't address the nerves, and they don't address the veins. And obvious, I mean, these things are self-evident, but they are worth evaluating because there are plenty of cases where hematoma evacuation should be your primary concern to free up the brachial plexus, to make sure that the bowel is okay next to said hematoma. And the ability to treat the lesion isn't necessarily mean that the lesion should be treated endovascularly. But that being said, it's clearly become the preferred method of management for vessels in difficult access locations. As an introductory talk, I would throw out and challenge everyone to think about these scenarios in your institution. Do you feel comfortable with your team to do endovascular therapy in someone who's unstable? We need to move towards the answer always being yes. Infant programs or programs that are continuing to develop, well, they were too sick for endovascular therapy. That should not be a thing that we talk about. What do you do with thrombotic lesions? Are you capable and comfortable with dealing with downstream embolization? What if they need open exploration at the same time? So someone needs a bowel operation, a laparotomy, but has a blunt celiac injury. Do we do that open because it's in front of us? Do we do both at the same time? I think we all have our own answers about how to do this. And does it matter how big the artery is? Have we gotten to the point that technology doesn't really matter for a 6-millimeter vessel? And I think these highlight some topics that we'll go over both in these cases and next week. Thanks for the opportunity to introduce this session, and I turn it over to my colleagues.
Yeah, just one quick point. We don't have a lot of time for discussion, but one of the things, Robbie, it was a great talk. One of the things you didn't mention, that there's a role for hybrid procedures where you may get control of bleeding with a proximally placed balloon and then do an open procedure to evacuate the hematoma and do the repair. So it's not necessarily one or the other. Would you just say a quick word about that, and then we'll move on? Thanks,
Dr. Veith. You're absolutely right, and this is one of the last slides cut. So I think that's where specially trained surgeons really can bring things to the front. The ability to do a stent graft for the axial subclavian segment, make a small incision and feel comfortable evacuating the hematoma through a hybrid procedure is absolutely why we need to highlight every team member's involvement in these cases.
Thank you, Rob. You're on for the next one.
Yes, sir, Dr. V. Thank you, Robbie, for an excellent presentation. I will remind everyone we are tight on time, but we have the option with the question and answer section to really engage in some different discussions offline and continue these even after the meeting. So utilize that question section on the Zoom application for that purpose. Our next speaker is one of my dear friends and partners here at University of Maryland. He's part of our endovascular resuscitation and trauma management team. And that is Dr. Rishi Kundi, yet another dual-trained surgical critical care and vascular surgeon. Dr. Kundi. Yep. Your mic let's see, is your mic open, Rishi? Your mic is muted.
We are working on this.
Can everyone hear me now?
Yes. Fire away, Rishi.
Good morning and hello to all of you. My thanks to Drs. Veith and Asher and Tal and Joe for this opportunity. There we go. My name, as Dr. DeBose said, is Rishi Kundi. I'm a vascular trauma surgeon at Shock Trauma. I'm the person in this picture who's not Johnny, Joe, or Dr. Scalea. So the case I'm going to be presenting today is our patient, a young woman who was PED struck and taken to an outside hospital. There, she was intubated and scanned before being transferred to our institution. On arrival, she was hemodynamically stable, ventilated. She had no neurological deficits when woken up. She arrived on an esmolol drip for impulse control, and this had been started because of the blunt thoracic aortic injury that we'll discuss. They also visualized on the CT that had been done the findings listed above, including injuries to both carotids and the right vertebral. Here are some selected excerpts from those studies. The right ICA occluded at the level of C1 with intracranial reconstitution. The left ICA bore a small pseudoaneurysm at the same level. The right vert was read as having a dissection with 50% stenosis, but on review, I think this was a fairly soft call, and the irregularity was really just a segmental cervical muscular branch. The aortic injury was not equivocal, however, and inconveniently located with the proximal edge of the injury right at the level of the left subclavian. So when I talk to patients about elective cerebrovascular disease, I use the engines of a 747 as metaphor for the redundancy of the circulation. So what we had with this patient was one engine that had apparently blown up, another that was on fire, a rumor that a third was smoking, and a flight engineer saying we had to cut fuel lines to the last engine in order to keep the wings on. Because of this, we opted to pursue a strategy to preserve perfusion to the vertebral with a TVAR with retrograde laser fenestration, which is something that's been very well described in both the elective and a few cases of emergent aneurysm repair. Because of the need for rapidity, we just obtained femoral and brachial access simultaneously, had a wire from the arm going into the descending aorta as the Lundquist was coming up from below, had a working sheath in the axillary but distal to the takeoff of the vert by the time the device was being positioned. Immediately after we deployed, we lased and dilated, used a short VBX for the takeoff of the subclavian. All told, we had occluded the subclavian for less than 10 minutes, which is important because we didn't heparinize given the patient's existing subdural. And the whole procedure was less than 90 minutes from beginning to end. Naturally, the angiograms from the procedure itself were unable to be brought over, but here's the CTA at 48 hours. We've done a handful of these cases now, and we have found that because of the variability in the subclavian origin's clock position, as well as the angle of its takeoff, the down the barrel view is absolutely critical for these. So other things on that post-op scan were interesting. The aortic injury had been excluded. The right vertebral was in fact uninjured at this point. And the right ICA had actually recanalized and now had a hemodynamically significant stenosis, possibly from a pseudoaneurysm that was appeared to be more than 3/4. The left ICA had a grade 2 injury rather than a grade 3 and had less than 50% stenosis. We opted to anticoagulate and observe for the short term with planned repeat angiography. And at 2 weeks, the picture was slightly clearer. A good deal of the lumen, the true lumen of the right carotid, was compromised by a circumferential, almost spiral pseudoaneurysm. Hopefully this may make that a little bit clearer. At its worst point, this resulted in about an 80% stenosis. Now, dynamically, we have this. This is contrast injection from the left uninjured side. And as you can see, the left internal carotid provided almost all of the perfusion for the brain because there was very little right-sided pressure to oppose. So we performed a left TCAR with flow reversal because on both the repeat CT scan and our catheter-based angio, there was some question about whether that occlusion, as it had recanalized, the occlusion now was accompanied by a mobile thrombus or a mobile dissection flap. Our goal was not to exclude the pseudoaneurysm by any means, but simply to eliminate the stenosis. And here's our completion angio, again injected from the left carotid. You can see that the right-sided pressure is now sufficient not only to minimize the crossover perfusion, there is a little wedge-shaped right at the apex that you can see there is asymmetry, but the contrast is now refluxing into the external carotid. In summary, our patient is now at home, back to her baseline status. The case did establish, this was our first, that emergent laser fenestration and left subclavian branching is feasible. And since blunt cerebrovascular injury and aortic injury are not at all uncommon to be coincident, I think this is not a trivial thing that we've established. Thank you, and I am open to any questions.
Rishi, if Dr. Veith, with your permission, I think one of the things this case really drives home to me is that we need to pay attention with these blunt thoracic aortic injuries to the status of the cerebral perfusion. In particular, there's that vertebral dominance. And we do that frequently in considerations of vascular surgery, but it's something that you really have to educate the trauma community on. Can you talk about how you, what's your routine for looking at the vertebral perfusion for these brain injuries when considering left subclavian coverage or revascularization?
I think that if you have the luxury of a few minutes, actually doing a high frame rate injection from the arch and even selectively to establish exactly what's necessary to provide perfusion and what is dominant is very useful, particularly when we have done repairs on the proximal subclavian or the innominate. One of the things we've done is test balloon occlusion with injection to see if I occlude, for instance, the proximal right subclavian, if contralateral filling is enough to provide retrograde flow from the vertebral with an arch injection. So if I come in from the right radial, occlude the takeoff of the right subclavian, and then do an arch injection, and I see contrast coming briskly down the right vertebral, then I can be fairly confident that the takeoff of the subclavian can be excluded and perfusion to the brain can be maintained. One of the things that is really useful about a high frame rate is that it gives you much better temporal resolution to determine where the blood flow is coming from and what's dominant and what's necessary.
Yeah, Rishi, is Frank Veith here. That was really a dramatic case, but for those who might not be expert at laser fenestration, another alternative would be a periscope graft, where your flow comes from below the TVAR and goes up to the subclavian. It's sort of a reverse chimney graft, where the actual graft is alongside the TVAR. What do you think of that as an option?
I think that both the snorkel periscope has probably more, of course we don't have data, intuitively has more durability in an aneurysmal context, just because of the overall dilation of the aorta. But the other thing that we have a bit more luxury with blunt traumatic injury, insofar as we literally just need to cover, to cover the aortic or the intimal injury. We didn't need a seal zone. We weren't bridging over a chasm so much as we were just kind of laying a patch over a hole. And because of this, I think that we have a lot more room to fenestrate, because the fenestration is not opening up the possibility of a type 3 endo leak.
I guess we got to move on. That's good.
Yes,
Joe,
sir.
you want to introduce the next one?
Of course, Dr. Veith. So now next we'll be discussing Dr. Erin Kelling. We're not going too far down the road from here in Baltimore to Bethesda, Maryland, and we look forward to her case presentation. Erin, it's your turn.
All right, thank you, everybody. Let's see if I can share my screen.
Yep, if your volume's a little low, if you could speak up or speak in or turn it up, that'd be helpful.
Okay, is that better?
A little bit. You may have to project a little.
Okay,
And we are working to bring you up.
thank you.
Until we managed to bring you up, if I might comment, there was a question from Sheldon, or just he wanted to hear a bit more about the laser fenestration. Probably Rishi can tell us very shortly. Just a comment until Erin comes up.
I was actually
How was the
just giving the answer. The Spectranetics laser atherectomy catheter is advanced up the arm until the tip is right up against the fabric of the endograft, and then it's fired. The duration of the firing depends on the graft you use because of the fabric. The Medtronic graft is the one that's most typically associated with the laser and can be fenestrated in about 30 seconds. The Gore is a much thicker fabric, and the last time we did one of those, we were firing for about 2 minutes total time.
Yeah. Okay, thank you.
Thank you. Go ahead, Erin.
Okay. So I'm Erin Colling. I'm one of the vascular surgeons at Walter Reed, just down the road from our friends at Shock Trauma.
We can't see your slides, I'm afraid.
Oh, okay. Let me try again.
Share screen or whatever.
There
Is
you
that
go.
better?
Great.
Okay. So I'm going to be talking about a case of a delayed endovascular treatment of a subclavian artery injury. We had a 29-year-old male. He was in a motorcycle crash. He was initially admitted to an outside hospital and had multiple injuries, including a T5 paraplegia. He had some severe left upper extremity injuries, including his subclavian artery, vein, and his brachial plexus. So he had no motor or sensory function of his left upper extremity. He did not have any revascularization at that outside hospital because they deemed that arm to be viable, but he was started on anticoagulation for his DVT. So he was transferred to Walter Reed. On exam, his arm was warm. It was edematous from the DVT. He did not have a pulse, but he had good signals in his radial and ulnar arteries, as well as his palmar arch. Like I said before, he had no motor function or sensation in that extremity. On vascular lab, he had flow in his brachial artery. He had a decreased blood pressure on that side, and his injured extremity index was 0.7. Here is a video of his CTA. You can see that the left subclavian artery occludes. There's a hematoma in that area. And then distally, it reconstitutes from collaterals. So at this point, his arm seemed viable. We didn't think he was at risk to have arm claudication in the future because of the function of his arm. And so there was no revascularization pursued at this point. Unfortunately, he went on to develop these hand ulcers. This happened after he had compression sleeve and glove fitted. His vascular exam was unchanged and his vascular lab studies were the same. The patient was very adamant that he wanted everything done possible to heal this hand. And so we took him for an angiogram. You can see the subclavian artery occludes. He's starting to form collaterals here. We placed a sheath from the groin. We wanted to avoid sticking his arm because of the swelling. You can see that the injury is distal to his vert, takeoff, and his lima. We weren't able to cross this just from the groin, so we stuck his brachial artery as well. And it was a little tough, but we were able to cross it from the brachial side, snare the wire, and body floss him. We then placed a Viabon distal to the takeoff of the vert and the lima. And he had good flow distally after that. So post-operatively, he had palpable pulses and symmetric blood pressures. He was transferred to a rehab hospital and his hand ulcers have healed. So this case was a little bit interesting because of the timing of the repair. I'm a little curious if anyone would have revascularized him on his initial presentation. Also, the use of the compression garments was probably predictable given his DVT, and so possibly we should have revascularized him earlier than we did. And I'm also curious on everyone's thoughts on revascularization for a non-functional extremity, especially if he had needed an open repair, if we hadn't been able to cross it endovascularly. I wonder if anyone would have offered him an open bypass for that arm. Thank you.
Thank you, Aaron.
That's a really nice case. One short historical note, we did the first 5 endovascular graft treatment of subclavian artery injuries. At that time, there were lots of them in the Bronx. And we thought this was really groundbreaking because it's such a hard open operation. We presented at the American College of Surgeons these 5 cases, and we were roundly criticized for, this was back in 94 and 95, for spoiling a good open operation. So things have really changed. Very nice presentation.
Aaron, can you talk a little bit about, you mentioned the body floss, also called rendezvous technique, or a variety of different things. We've got some people in the audience maybe not familiar with that. What's the basic things you have to think about? I know one of the pitfalls I always encounter, we've prepared these very early in that same fashion at Shock Trauma, and we always occasionally get stuck with a wire that's too short to put the delivery device on. Talk a little bit about what that is specifically, that rendezvous or body floss technique, and what are the quick tips? Yeah, so the rendezvous or body floss technique is where you catch you snare a wire from one access point and you pull it through the other access point. So then we call it a body floss because you're going to have a wire going in this case, through his brachial artery, down his aorta, and out through his groin. So that's where the body floss term comes from. I think you pointed out the probably biggest pitfall and the most common mistake I've made, which is using a wire that's not long enough, because you need enough length of wire, not only to go from one access point to the other, but then also to deliver your, device, your stent or whatever it is over that. So I think being aware if you think you're potentially going to body floss, to choose a long wire initially is the biggest thing. The other thing, if you can put a catheter over that, then you could stick a longer wire later. But choosing a longer wire from the start is usually the best choice.
Yeah, there's one other little point on this, that if you have body floss across the origin of the subclavian, you just have a wire across that origin and you pull too hard, you can lacerate the origin of the subclavian. We've done that once in the past. It's a fatal injury, and we would not do it again. So if you do have a wire and you're pulling, you should have a catheter to protect the wire from lacerating the subclavian.
And as devices continue to improve, we've been able to do most of these by radial access, using the Terumo radial access system, especially with the smaller VBX diameters. That's worked out really nicely for us. Excellent, Aaron. Let's move on now. Let's jump across the ocean now to have Dr. Nigel Ty present for us. Dr. Ty just recently completed I think the last edition of the Vascular Trauma textbook is now in press, and a monumental undertaking which we're thankful for. And Dr. Ty is going to present a case for us.
Hi, good morning or afternoon, everybody. Thank you very much for the opportunity. The Royal London Hospital serves the northeast quadrant of the Greater London area, and we're also the host for the London's Air Ambulance, which serves the whole of the Greater London area within the M25 orbital motorway. The London's Air Ambulance is notable for many features, but one of those is that following the successful institution of the REBOA program at the Royal London Hospital, our major trauma centre, they deployed it in the field in 2014, did the world's first pre-hospital REBOA, and subsequently wrote up their experience, which demonstrated that it was feasible, that it was associated with the kind of physiological change that you would expect with the deployment of REBOA, but there was a complication rate associated with thrombectomy and runoff vessels. So the case that I'm going to relay to you began early in the evening following a stabbing to a young gentleman who sustained injury to his right groin. The call was made at 19 hours. The EMS attended and then requested backup from pre-hospital physicians mediated by the response cars of the London Air Ambulance. They arrived on scene at 20:02. And at that time, they found that the patient had been retrieved into the back of an ambulance and been given some crystalloid that was combative, very pale. A tourniquet had been applied to the right groin. There was a pool of blood on the ground where the patient had been moved from. And this illustrates their understanding of the injury set at the time. There was a high groin incision, about 5 centimeters in length. They were already suspecting iliac vessel injury. So the actions on, they proceeded to cannulate the left femoral catheter with a 4 French sheath whilst giving a unit of blood pre-hospitally. The patient's agitation settled down. They noticed some bleeding coming from the tourniquet site, not much, so they took that down to assess. That bleeding became worse, so they applied direct pressure, packed in some Celox, and they upgraded their left-sided 4 French to an 8 French with the anticipation of doing REBOA. They were unable to get the first REBOA catheter through the sheath for some reason. They were unable to advance, so they managed to extricate the catheter, and then they carry a backup catheter which they deployed without any problem, passed up to 30 centimeter for a zone 3. They inflated to 5 but didn't get sufficient tactile feedback that it was occluding, and also it was still bleeding from the right groin, so they popped another 3 mils of saline into the balloon and got control and noted that the physiology was improving. So first blood pressure on scene prior to REBOA was 50 systolic, and you'll note that they weren't able to get any saturations at all from the O2 probe, suggesting the patient was in a critical circulatory situation. The last blood pressure was post-REBOA was 88 before they moved to the major trauma center, where I arrived in the operating theatre. They bypassed the ED, went straight to operating theatre. We then got control of the situation by performing an extraperitoneal approach down to the right groin, down to the right external iliac artery and vein once the patient was anaesthetized. Once we'd got control, we then deflated the REBOA catheter in a stepwise fashion to deal with any ischemia reperfusion issues. Then took the catheter out, left the sheath in, and then repaired what was a nasty near transection of both external iliac artery and external iliac vein towards the junction with the common femoral systems. And that kind of sums up what we did. We left the sheath in until that was the last thing we did, apart from the fasciotomies, and the patient got blood products, as you can see. So we put this through our D&D, M&M process basically, and we found that there was the team exhibited good practice for placing the sheath in anticipation of the patient requiring REBOA and giving them some room to upgun later on. They also exhibited good practice with regard to taking the patient straight to the OR, bypassing the emergency department and continuing the resuscitation there, and also for dealing well with their technical challenges. This is the patient. It would not be true to say that he's returned to baseline, because he, as a result of stab injury, he has a femoral nerve injury as well, from which he is rehabilitating, and he has a degree of chronic pain as a result of that. But nonetheless, there he is caring for his newborn child. We're running a study at the moment at London's Air Ambulance, which is looking at the use of P-Reboa in the pre-hospital environment, and we're recruiting eight patients to study feasibility of that. I'd just like to pay tribute to the Air Ambulance doctor, Dr. Costi Cocco, who was the operator, plus his team, Dr. Clare and Mr. Whitehouse, the paramedic, and of course the lead for Air Reboa within the pre-hospital environment for London's Air Ambulance, Dr. Lendrum and Dr. Sadek. Thank you very much indeed.
That's a beautiful case, Nigel. One quick question. The sheath was placed in the air ambulance, correct?
No, that's negative, sir. So the air ambulance has two means of deploying pre-hospital physicians. One via the air ambulance itself, and the second via a fast response car. And they have their own criteria for deciding whether to launch via the helicopter or via the fast response car. In this case, the physicians were deployed by the fast response car to the site of the injury, and the patient at that point was already in the back of an ambulance. And so the pre-hospital Reboa was conducted in the back of an ambulance whilst that ambulance was static. It wasn't done on the move.
Okay. Then it was done by a physician or surgeon?
It was done by an emergency medicine physician. The London's Air Ambulance is staffed by emergency medicine trained physicians who generally come from emergency medicine or anesthesia backgrounds, although one of my colleagues, Mr. Zane Perkins, who is a trauma surgeon, he also staffs that rota as well.
Nigel, one follow-on quick question. You talked a little bit about the PI process. I think that clearly HEMS is the standard of care in terms of implementing this in the pre-hospital environment. You have a robust training. You have a team-based platform that incorporates both surgeons and pre-hospital providers into the training and development. What about the PI process? Is that you look at all your Reboa outcomes and learn from each experience in a multidisciplinary fashion? What's the team-based approach to that?
Great question. So after every Reboa, we run that through a specialized mortality morbidity meeting, which is just dedicated for Reboa, and it allows at least 60 minutes to discuss and refine the learning from each case. I think it's fair to say that we're still on a journey, because these cases, although they happen they're not infrequent, but they're not sufficient volume for us to be able to step away from a carefully calibrated learning session that allows us to extract maximum learning from each case.
Well, we're precisely on time, believe it or not. I congratulate all the speakers. The cases were remarkable. Robbie, your presentation was excellent. We'll move on to our next topic, which is embolization with coils, plugs, and hemostatics. And an overview will be provided by Pedro Teixeira from Austin, Texas. Pedro, you're on.
We are bringing him on. And then we will try also, I can say also, we can try to take out comments if we have time in the break. And this will be lead of you, Professor VEITH, and the boss.
Everyone see my screen?
Yes.
Not
yeah.
Yet.
Good afternoon.
There we go.
Need your slides. We saw them for a second.
Share again.
Coming.
There you go. They're up.
There you go. All right. So thank you for the invitation. It's really great to be together with this group of people with so many shared interests. Those are my disclosures. So I'm going to give a brief overview regarding embolizations. We are in the business of stopping bleeding, right? This is what we do. Sometimes it has to be done right away. Sometimes in a more controlled fashion. And at the present date, it's impossible to think about management of trauma without an environment similar to this. You know, the rooms are going to be somewhat different. The setup's going to be somewhat different, but it's impossible in my mind to consider like adequate trauma care without some type of catheter-based intervention, because those interventions are an adjunct to other bleeding control strategies, and they're very important. So when we look at what we do, a lot of the angioembolization techniques are significantly important for pelvic fracture multimodal approach, and a lot of importance also in solid organ injury non-operative management adjunct. And we talked about some areas where bleeding control is just too difficult for open repair, and the catheter-based therapy would play an important role in those areas. So for pelvic, for example, I mean, the multimodal approach has changed the way we manage pelvic fractures, the binders, the one-to-one resuscitation, they use the Reboa, preperitoneal packing, but the endovascular pelvic embolization, really important. When a few years ago we looked at prospectively just over 600 patients with pelvic fractures, we saw that 1/4 of those patients got an angiogram and 2/3 had a positive angiogram. So I mean, it's a very important tool in the management of these patients. We just recently reviewed the management of splenic injuries in our Texas trauma study group, which included 9 level 1 trauma centers over 7 years, just over 5,200 splenic injuries. 8% got an angioembolization with an overall success rate of 92%, which mostly included higher grades of injury. So it's a pretty important adjunct to these techniques. So let's go through some basic embolization rules. So first of all, we need to have a plan, because as we discussed, you need special equipment, you need to know what you're going to do, and that's really important. Maintain a stable, secure catheter position is critical, because, you know, access, like it was discussed before, is very important. And after you obtain access and you have access to where you're going to deliver your particles or whatever device you're going to use, is very important to have it secured. The use of coaxial microcatheters for small vessels, because you have the guiding catheter to maintain that position, is very important. Embolize to a predetermined endpoint. Just have a plan. So what your expected result. Try to avoid that, oh, let me just put another coil, or let me just give another flush of gel foam, because that's where the complications start. And then document the results, checking for collateral reconstitution in areas of distal occlusion. You always want to see if there's any back door that you still need to consider and stop the bleeding in the area. So starting with the coils. Coils are very interesting devices. I mean, they're being used for a long time. And the important thing about coils is that they are available in a variety of sizes, lengths, shapes, and materials. Application is really wide. They occlude the vessels by physically obstructing the lumen. So it's a permanent occlusion. We need to read the labels carefully, because if I go to my coil cart, is like an infinite number of options, and at that time you really want to make sure that you're choosing the dimension of a coil that matches with the vessel you're using, that especially if you're not using a detachable coil, that the coil is going to be large enough for the catheter you're using to avoid jamming the coil inside the catheter, and that the wire that you're pushing also is of appropriate size, so you don't jam the pushing wire behind on the side of the coil. So the final diameter of the coil should be around 20 to 30% larger than the vessel that you intend to close. Try to avoid sharp angles or redundancy with your delivery catheter, because that may be hard to push coils, especially larger caliber and long coils. And then always remember to gentle forward pressure on the catheter to help pack, because you really want that coil to shape adequately to pack well, so that you can achieve the intended occlusion of the vessel. Similar technique, which also achieves the permanent occlusion of the vessel, is the plugs. I mean, the plugs are an important tool, very useful for large vessels, because you would need a ton of coils. So instead you can use a plug. It's really interesting because you can create that rapid occlusion of the vessel with a limited number of devices. You just put one plug and it will be it. The fact of it being detachable, you can deploy it, evaluate the result, and then release the device. So there is room for adjustment in your technique. And it serves as a scaffold for rapid thrombosis formation that completes the occlusion usually within 5 to 10 minutes. So it's not immediate, but it's a pretty quick occlusion of that vessel. And then we have things like gel foam, which is a workhorse of angioembolization, both in the visceral areas and especially in the pelvis. How you do it is a lot of it is user preference. We can just get the gel foam, cut it, and mix with the contrast solution with saline. We have option of pre-made gelatin-based products that come already ready on a syringe with a slightly higher cost, but very convenient. So some important principles is that you have to cut that dry brick of gel foam into pieces, put in the syringe, soak with the contrast. The concentration is going to vary according to your preference. I typically use half and half. The multiple small cubes can be injected with 3 to 5 cc syringe, and you can use the torpedoes, which is basically a small cylinder of gel foam that can be delivered with a 1 cc syringe. Very useful when you're mixing coils and gel foam. You can put a coil, put a torpedo, and then put a coil again, and then you create that sandwich. Very useful to safely occlude a vessel. And remember, it's a temporary occlusion. These are going to recannulate later, which is very interesting in, for example, the pelvic circulation, which you will achieve your hemostatic goal and then recannulate the pelvis later. The smaller pieces may be necessary for the microcatheters. And remember, this is always going to plug the catheter, so flush with a 1 cc syringe to generate enough pressure to clear that catheter after each injection. And if it gets stuck, use the small syringe to clear the catheter. And then we have things like onyx. Onyx is a very interesting liquid, which is almost like a hybrid between what you achieve with the coils and plugs and what you achieve with the gel foam in terms of migration to the distal circulation. It requires some preparation though. So the application in trauma is a little bit more limited, but you need to consider it's interesting the way it works. So if people that did not have experience using onyx, it behaves like the volcanic lava. It polymerizes on the outside and keeps flowing on the inside. So it pushes through the flow and reaches further down the bloodstream. But you need preparation time. So you need to start agitating the bottles in the beginning of the case. You need at least 20 to 25 minutes for the product to be ready. You need to select the viscosity based on the flow and the lesion depth of penetration, though the less viscous is going to be carried away more distally by the bloodstream. And there's a lot of technical points about delivering this agent that are very important, because otherwise it's going to get stuck inside the catheter. So the catheters need to be compatible. We need to flush the microcatheter with saline. The catheter needs to be loaded with the MSO before injecting the onyx to avoid immediate start polymerization. And then the onyx needs to be injected slowly, allowing that bead to form at the catheter tip. Then you see the lava coming out, and then you keep pushing, and then it's going to polymerize from outside in. So in summary, angioembolization is an integral part of trauma care. It's unimaginable to us to manage trauma patients without these techniques. We need to be familiar with agents' properties and the delivery techniques, even if you're not the one doing the procedure. It's important to understand how the gel foam is going to work in the pelvis, how the coils are going to have a potential use in the visceral circulation, and beware of complications associated with angioembolization. And we're going to discuss a little bit of complications in the cases to be presented. Thank you.
Pedro, it's very, very nice talk. I'm sure we'll come back to you if we have time to discuss the complications, but we now have 2 cases. The first one will be by Abdul Al from Houston, Texas. So Abdul, you're on.
All right. Thank you so much for inviting me to this conference. Do you guys see my slides or?
No, we just see you.
Reshare them one more time.
Oh, okay.
Hit good.
Great.
I think you have to hit slideshow up
And
at the
you
top.
go to your first slide. Slide up to there.
Good.
Sorry. Okay. Here you go. So we're going to talk about some cases, trauma patients. So these are my disclosures. And the type of cases that I really chose to talk about are specific. The first type of cases are the splenic injury cases. We all know that splenic injury is one of the most common injuries in trauma. So this is a patient who is 72-year-old male with a history of fall. He was hemodynamically stable, so he was sent to us for embolization. As you can see, he has multiple pseudoaneurysms in his spleen, and this is a grade 3, was classified as grade 3 splenic injury. When you see here, we tried to do an angiogram for the celiac artery, and you can see there is multiple pseudoaneurysms very distally inside the spleen. And the way we embolized this one is we went very distally with a microcatheter into the tiny little branches of the splenic artery, and we coiled each one of them after injecting some gel foam first, and then we coiled each one of these arteries. So we ended up like occluding all these pseudoaneurysms. And again, I think it was mentioned several times by several of the speakers today that this, you know, if you're going to do endovascular technique, you have to have honestly a dedicated training so that you can get a good catheter wire technique to be able to do these sometimes complex cases. But this is how we did it in the past in general. And of course, there's a risk here that when you go so distal like this and you inject gel foam as well, that you will get ischemia, and that might end up with splenic infarcts and later on, you know, infection. And so you'll end up with splenectomy anyways. So, but this is how we did it several years ago. These days, we have changed our techniques a little bit. And this is just a similar case where it's also grade 3 splenic injury. You can see the laceration here in the spleen. And you can see the significant tortuosity in the splenic artery here. So the way we do it these days is we try to, again, pass a microcatheter to the middle of the spleen. And then we start laying coils in the middle of the spleen. And this way, you can see that here, the left gastric artery is actually providing collaterals that eventually fill the distal part of the spleen. Sometimes it also comes from the dorsopancreatic or pancreatic and magna arteries, and they fill distally. And sometimes if you do also a more proximal angiogram, you'll see the gastroduodenal artery giving the gastroepiploic, which also fills the distal splenic artery. So this way, as you can see, this is a CT that was done after embolization. You can see that there is a consistent perfusion to the splenic tissue here. So the risk of ischemia is definitely less. We rely on the fact that when we embolize proximally, we reduce the pressure column going to the spleen. So it's unlikely, so the spleen is still perfused, but at a very low pressure, unlikely that it will result in a rupture of these pseudoaneurysms or bleeding. So this is another case, but in this one, you know, you can see that the splenic artery is more straight. It's not so tortuous like the other case. So in this one, we were able to deliver or pass a guiding catheter for the splenic artery. It's usually 6 French, and we placed Amplatzer vascular plugs that Dr. Teixeira just talked about. And after we placed them here, you can see 2 of them. We did an angiogram, and you can see it's again filling the splenic artery distally through these collaterals. The splenic artery itself is occluded here, but filled distally through collaterals at a very low pressure. Unlikely that this patient is going to bleed. So again, the difference between proximal and distal. Proximal is faster. You don't have to navigate too much into the splenic tissue. It lowers the pressure distally. This one occludes the target artery. There is less risk of infarction. There is high risk of infarction. And so the reason it's lower risk is because you are still perfusing it through collaterals. So it's unlikely that you will end up with splenectomy. This is a meta-analysis study that was done on 479 patients. Again, you know, there's no difference in the failure rates. Specifically, rebleeding was similar between proximal versus distal. They also had equivalent rates of infarction and infection between proximal and distal. So, you know, these days, honestly, everybody's moving more towards doing proximal embolization for splenic injuries. This is another case of pelvic injury after a gunshot wound. You can see again the importance of having a dedicated training and a good catheter wire technique if we're going to do endovascular treatment for our trauma patients. You can see here that the internal iliac artery on this side is open, but on this side is occluded, and the posterior trunk here is fed by collaterals from the lumbar artery, which communicates with the iliolumbar here. And you can see there is a pseudoaneurysm, a large one here in the pelvis that needs to be embolized. So in this case, we went with a 2 French microcatheter through all these collaterals down into the pseudoaneurysm. You can see it here. There's the microcatheter with its tip into pseudoaneurysm. Here's a better picture here. And we placed coils in that pseudoaneurysm. And of course, we pulled back. And then we placed also coils proximal and distal to occlude the back door. And here's the final image. You can see that there is no pseudoaneurysm. Again, emphasizes the importance of having a good catheter and wire technique. And that's all I have. Thank you so much.
Very good talk. One quick question. Is there really, at this point, any reason to do the distal embolization of the spleen? Because it seems that the results are equally good with the easier proximal embolization. Definitely people are still doing, some operators are still doing that. For me, I always do proximal. I never do distal anymore. There is really no reason to do that. And there's honestly no reason to use particles or specifically spherical particles anymore. Sometimes we use gel foam just to make sure that the coil is completely occluded. We just augment the coil placement with some gel foam, but I don't go distal anymore to inject gel foam or spherical particles. I think it has a high risk of infarction. Every time we do this, there's ischemia, and then the patient usually ends up, honestly, having his spleen taken out, which Thank you very much,
defies
Dr.
why we. Yeah.
Great talk and a lot of good points. Our last case in this particular session is to be presented by Paula Ferrata and Stefan Leichtel, both from Richmond, Virginia. I guess, Stefan, you're presenting it?
I am presenting, yes. Good morning. Well, thank you very much for having me here as part of this group, especially representing really more the a non-vascular trained trauma surgeon and more the good old ways that were mentioned earlier. So let me share my slides here, and I hope everybody can see the slide. So a couple of disclaimers. So this is actually another case of angioembolization for splenic injury that we just heard the talk before, but hopefully adding a different and interesting angle. At VCU, we do not perform angioembolizations ourselves, and we do not have endovascular trained trauma surgeons on staff, which means for us as clinicians, the question really always is, when do we ask our IR colleagues to perform angioembolization versus when do we do surgical treatment? Obviously, for solid organ injury and pelvic fractures, for other injuries, we might get our vascular colleagues on board. I have changed some patient details to ensure confidentiality. Now, this case is a 60-year-old man that presented to an outside institution first with acute and chronic abdominal pain. That patient unfortunately presents every couple of weeks to the ED. He had multiple abdominal operations, including ileostomy creation. So he was really more worked up first for chronic abdominal pain. And sometime throughout the workup, they found out that he sustained a groundable fall about 8 hours prior to the presentation to the outside institution. And of course, the patient has atrial fibrillation and is on Coumadin. At the outside institution, they got a CT scan, and they found that he has a grade 3 splenic injury with large subcapsular hematoma, extracapsular blood, which is beyond what that institution can manage. They do have access to a lot of expensive treatments, though. So he got vitamin K, TXA, and PCC, and was shipped to our institution, where he arrived about 14 hours after the injury. You can see the vital signs are pretty much normal, not tachycardic, although the patient is on a beta blocker. He has a tender abdomen, obviously a positive EFAST, and he has a urostomy and ileostomy with extensive abdominal scouring. His hemoglobin is 9, down from 11.5, and either because he never was therapeutic or because he got the PCC and vitamin K, his INR is actually normal. This is the CT scan from the outside institution that gives you an idea of the amount of hemoperitoneum as well as how the spleen looks. The spleen is still identifiable as organ, but you see the severe damage, especially along the inferior aspect, and highlighting that as well in those slides here that really points to the degree of splenic damage. AAST grade 3 is the official radiologic classification. So for us, of course, the question, seeing this patient 14 hours after the actual groundable fall, do we take out the spleen? Do we call IR? Do we perform angioembolization? And you could certainly make in a case like this multiple points. You can say, let's go to the OR. That's a grade 3 splenic laceration. We got active extravasation, large hemoperitoneum, tender abdomen, and not to forget the patient will need to be anticoagulated soon again for his atrial fibrillation. At the same time, the patient really has minimal extravasation on the follow-up CT scan he got here, normal vital signs. He clearly has a hostile abdomen with his prior operations, and he's no longer coagulopathic. So we did go down the IR embolization route, and that was done pretty much as described just in the case before as a proximal embolization. And there was actually no extravasation found by our IR colleagues here. They performed coil embolization of the proximal splenic artery and had really no concerns and good collateral flow after the embolization. You see two still images here before and after the angioembolization, as well as the attempt to capture that on video. Now, the patient did fine for about 48 hours in the ICU. Afterwards, his hemoglobin levels essentially unchanged, and he got promptly transferred out of the ICU after 2 days, just to have a morning hemoglobin the next day of 8. And you see the relevant images here. I also couldn't help but highlight the nice CT image of multiple gallstones, which you don't see often, but has really nothing to do with the case, just interesting surgically. But most importantly, you see the spleen that now really is even more replaced with hematoma. So the patient ended up going to the operating room, 2 liters hemoperitoneum, fresh and clotted blood, had the spleen taken out, got extubated, returned to the ICU, and since then has been recovering well. So the takeaway for this case, really by double AST grade, and there's multiple studies on this, his angioembolization and non-operative management should really have been highly successful. I think as trauma surgeons, we often see some risk factors that we just know the spleen, that patient will not do well. Large hemoperitoneum being one of them, but also just the morphology of the spleen. I think in this case, having this large aspect along the injury along the inferior aspect of the spleen, having seen several cases like this, you just know there is a high risk of them having delayed rupture despite angioembolization. And that is the case. Happy to answer any questions.
Yeah, Stefan, that really was a very instructive case, and it brings up the point that was made by several speakers, I think, Joe and Ravi, that the management of these trauma cases, particularly when one is involved in endovascular procedures, has to be a collaborative effort. And our feeling has always been that the collaboration depends, it's a local phenomenon. It depends on the skills and interests of the various specialists in a given hospital or a given locale. And in some cases, the vascular surgeon can do it all. In other cases, they can't do it all. You need the trauma surgeon and the IR people and maybe even a cardiologist here and there. Would you comment on that, the importance of local determination of who should be involved in these cases? And getting help is always a good thing.
Absolutely. I think some of the presentations and overviews we've heard today are possible at very few select places where there are people that are dually trained. I think in many institutions, and we are a big trauma center with all the resources, just more of a traditional team approach. So we really need to get vascular surgery on board for certain vascular injuries. As mentioned earlier, we're very happy that we can call our vascular colleagues in, do TVARs, help out with aortic injuries. We usually do our proximal peripheral injuries ourselves as trauma surgeons. IR, we get in for solid organ injury or for pelvic fractures. So really, I think the key is to have either the team available or to have a few select institutions, the 1 or 2 people who can do it all because they have extra training. But those are the 2 approaches to successfully manage these patients.
That's great. Well, we're right on time. I guess we're 1 minute behind. And Joe, do you want to take over and do the last session?
Yes, sir. I'll be happy to introduce it. Again, I remind all attendees and panelists, use the question function because we can carry on some conversations there even after this meeting ends to answer some of the questions from the viewers. Our next session is the civilian and military updates for Ebola. And our first speaker I'm going to introduce to provide an overview, my senior partner and the only endovascular trauma designated director that I know of at a U.S. or European trauma institution. He's the director of our dedicated endovascular trauma service, Dr. Johnny Morrison. Johnny, would you like to give us an overview?
Great, thanks, Joe. Thanks very much for introducing me. Give me a thumbs up if you can see my slides. Great, thank you. So we're moving on to onto a slightly different topic. We've focused largely on the kind of finesse of patients who have been able to undergo kind of semi-elective or planned procedures who are generally hemodynamically stable. We're moving on to the topic of resuscitative endovascular balloon occlusion of the aorta, which is really a tool that's used at the other end of the spectrum in patients who are hemodynamically unstable and very unwell. my conflict of interest to declare clinical advisory board member of Primetime Medical. So the evidence around resuscitative endovascular balloon occlusion of the aorta is, I would be fair to describe as unclear at present. This is something where we very much have an evolving evidence base. In terms of background, this is a tool whereby a catheter is placed into the femoral artery and advanced into the aorta, and then the balloon is inflated, and it can be inflated in the thoracic aorta for proximal control of the abdomen and pelvis and lower extremities, or it can be placed into the infrarenal aorta and used as a method of controlling pelvic inflow. This is more than just a hemorrhage control adjunct in that it also provides cardiac afterload, so it has a resuscitative effect. And that's very important because when you have shocked patients who have a low blood pressure, this is a tool that will elevate that blood pressure and increase central perfusion. So it's more than just a hemorrhage control technique, and this is something that's kind of been formalized since this procedures and techniques paper was written in 2011, and since then it's kind of emerged into trauma centers with some dedicated tools. In terms of evidence, this is where we really run into an interesting time where the trauma population where this has been used is often one of the most complex populations. They have often a very wide injury pattern, very heterogeneous, which makes it difficult to study. One of the largest bodies of evidence comes from Japan, interestingly, who have been using this as an adjunct for the last 10 years and have some of the largest data sets available, although Dr. DeBose is certainly catching up. And one of the things that I find interesting is the fact that with the same data set, depending on how you analyze it, you can come out with diametrically opposite results. On the left-hand panel, I have a study by Nori et al. Published in about 2015, where they did a propensity score matched analysis of patients undergoing REBOA and those undergoing no REBOA as part of their care, and we find that REBOA was associated with a significant mortality rate in contrast to the no REBOA patients. The same data set was then analyzed a different way by a different group of investigators a few years later, who were able to demonstrate that there was in fact a mortality benefit. So this is why we hit the problem of how we understand this data. In terms of where we are in the US, I think it's fair to say that we're in a kind of nascent learning curve. I think the same things apply to Europe and beyond. This is data from Bilal Joseph and his group in Arizona, who used the National Trauma Data Bank, the Trauma Quality Improvement Program, to look at patients who received REBOA in the US, and found that it was associated with an increase in mortality and also an increase in morbidity in terms of amputation rate and renal failure. So one of the questions I think that we're left with is this a new adjunct that we are ascending the learning curve, or is this a flawed intervention that isn't actually associated with benefit? And this is what we are trying to unravel at present. In terms of update, I'm able to share some data from our center in Baltimore, where we've been using REBOA now since about 2013. This is data from 2015 to 2020 in terms of REBOA patients, where we've taken our kind of REBOA experience over that time and then matched it with both a contemporaneous group who were treated at the same time. But in an effort to remove the selection bias of having the adjunct available, we also matched to a historic cohort of the previous decade, accepting that there are some methodological issues with that. But what we found is that compared to both groups, we've been able to demonstrate that there is a survival advantage on our log rank test, where if you come into the shock trauma center and you're managed with a REBOA catheter, your survival is higher than if you're managed without a balloon. So that's kind of our experience where a single center is using an adjunct frequently. And as I say, it remains to be seen as to whether this is something which translates globally. What we are finding is that as a technique, this is something that evolves as we learn new ways of doing things. One of the things that I think is emerging is partial REBOA, this notion where you're trying to balance the amount of hemostatic support versus distal perfusion, where you have either end of the spectrum if the balloon is up or down. And partial occlusion is the concept where you try and balance a level of flow through that still provides you with some hemodynamic support and hemorrhage control, but you're able to supply some distal perfusion. This is a quick picture of the operating room that I took when Joe DeBose was doing a case, where you can see that there is an arterial line below the balloon, which is the white line, which is tracking a little bit of flow through that he's allowing through the balloon, and then a proximal pressure, which is a fairly healthy pressure, which is going to the heart and the head. Whereas the lower extremities still have some perfusion. And this is how we are very much using this at shock. What we found is, if we look at this, is that 30 minutes is very much our cutoff where we start to see a rise in mortality. And when we use partial occlusion, although we just have small numbers, we're starting to see that there is a reduction in the amount of vasopressors and some organ support that patients require. So in summary, REBOA is one of these tools that very much started life as a military adjunct. It's now been extended to civilian practice. I'd say that we're in a kind of phase of equipoise at the moment where the data is unclear, but as experience grows, our outcomes are improving. And I think certainly volume is part of that. There are new techniques emerging from this body of literature. And just to bang on a kind of hobby horse of mine, a trial may be something that may help, and that this is something that I think is sitting ripe for a randomized trial. Well, that brings me to the kind of end of my brief update. Keen to take any questions before we get into the...
Yeah, Johnny, that was really excellent, but don't you think the secret is picking the patient for the REBOA? I mean, there's some patients where it's a no-brainer. It's going to save their life. They're bleeding out, and a balloon can give them a chance at survival. The other problem is if you put the REBOA in patients that really don't need it, you're going to get all the complications without any of the benefits. So isn't patient selection for it the whole key?
Dr. Veith, absolutely. I think that's the key to many complex interventions. What we find is that many of these patients are very fast moving, and therefore your decision making and your ability to implement your REBOA catheter is also a key stumbling block. And there's a tendency to try and get early access for monitoring and then use that to help try and make your decision making. But absolutely, I think that picking the right patient is really crucial, and I think that that's a really fine line between the patients who'll the patients who benefit versus those who won't. But yes, I think they're absolutely wise words.
Well, with that, Dr. Veith, with your permission, we'll move on to stay on schedule here up to your neck of the woods, to the Bronx, where Edward Chow and Sheldon Tepperman have a case that may illustrate some of these points for discussion for us. See your faces, but not your slides.
You're getting them. You're getting them. So I just want to say at the outset and pay homage to my old professor, Dr. Veith. Dr. Veith trained me in the 80s. So many fond memories of all-night surgeries for limb salvage. Good to see you, Frank.
Nice seeing you.
Also, Joe, you and Todd Rasmussen, Megan Brenner came up to New York City and helped me teach hundreds of providers the new technique of REBOA. And I'm sitting next to Eddie Chow, who was famously pictured in the New York Times for having placed the first REBOA in New York City. And Eddie's going to present our case.
Thank you, everybody. This is our recent case that we've had. This was a level 1 trauma activation, came to our institution right around change of shift at 8:50 in the morning. She was a 72-year-old woman. No past medical history was known at the time, who was hit by a car, unfortunately. She was complaining of left hip pain only, which was her major complaint, and of note on her vital signs. Clearly, her blood pressure was very low, 62/39. MTP was activated. She got 4 units of PAC cells and 2 FFP in the trauma bay. Her transiently, her blood pressure did respond, but it quickly deteriorated back over to 70/Pal. We completed her primary survey, and of course, on the adjuncts, we found this, which is a APC3 open book pelvis fracture with dislocation of the SI joint in the back, and probably the culprit as to why she was so hypotensive. The rest of the survey, chest x-ray was normal, FAST was negative. She was intubated to secure her airway at the time. And as we were pulling for the pelvic binder, we were reminded that probably Ribot is the perfect indication, hitting on what we were just talking about the last case for a patient like this. And quickly we put in an arterial line in the left common femoral artery, upsized to a 7 French sheath, and then floated the Ribot to zone 3. Occlusion time was at 9:16 in the morning, and immediately her blood pressure improved from 70 over palp to 114 over 60. Again, since this was first thing in the morning, IR was present already. They were preparing the suite for us to arrive. They're the ones that do our embolizations and angios. So in the interventional suite, the Ribot balloon remained inflated until IR was ready to do their stick, and they were prepped and ready to go. We deflated just at that point, and that was our total aortic occlusion time of 33 minutes. And they went through the right common femoral, which was their access. Here's a picture of Josephine. I was hoping to show to Colonel Rasmussen, his niece. She was rotating with us at the time, and she's holding the box of the Ribot that bears her uncle's name. This was the hemipelvis angiogram showing active blush throughout distal peripheral branches all throughout the left hemipelvis, and it was the same on the right hemipelvis. So in fact, what we did was our IR colleagues placed bilateral coil embolizations and gel foam on top to take out those hypogastrics permanently. While we were there, we did a fluoroscopic cystogram to ensure that the bladder was not injured, and we also shot the hepatic and splenic beds to make sure there was no active extravasation, given that we hadn't gone to CAT scan yet. So needless to say, she stabilized after that, which bought us some time to go for a pan scan. She had an extensive list of injuries, including probably the most significant, which was her L1 burst fracture. Thankfully, she was still moving her legs. She had orthopedic injuries throughout, bilateral hemothoraces, and as well as a small subarachnoid hemorrhage in her brain. Day 2, she got stabilized from her pelvis with anterior and posterior screws to stabilize. And after that, she had a 14-day hospital day course, including a segmental spinal fusion of T12 to L2. Her tibial plateau was fixed. Her chest tubes were removed. She left weight bearing as tolerated, eating in good spirits to a subacute rehab facility.
Eddie, would she have exsanguinated and died without the Ribot?
I think prior to Ribot, this woman would have received ongoing transfusions, presented to the IR suite, and probably would have received at least twice, if not 3 times as much blood as she otherwise would have. Preperitoneal pelvic packing would have also been an option, but that not necessarily would have controlled the arterial bleed. So with Ribot, I think we saved her a lot of transfusion and then the ensuing complications from that.
All right.
Ed, let me ask you another question. I mean, you guys have really embraced this in New York, but it's not a high volume trauma environment that you folks have. So how do you maintain that sharp edge so that when everybody reaches for their Ribot, even if you haven't used it in 3 weeks, you're ready to go?
It's going to get worse in New York.
It may for now, but I mean, how do you it's a question that's open to anyone. How do you if this is a tool that you utilize infrequently at your institution, but you need it for that specific patient, how do you maintain the skill set as a trauma surgeon?
So on a quarterly basis, we will review and go over the steps again. We have online skills and referral tools that we go to, and then also
we bring the simulator in 4 times a year. The simulator
comes in 4 times a year in order for us to go through, and all the trauma surgeons that have been credentialed for it would go through that as well.
And what about the partnership with your vascular partners? I understand it's very good. You guys have that crosstalk across the specialties? Absolutely.
Both our vascular colleagues were my chief residents at one point at Montefiore, so we have a very good close relationship. Once the balloon goes up, they're pretty much immediately alerted and on their way to come help me out.
That's great.
It was a great case.
Yes, sir. Absolutely. Great save. Well-deserved recognition there. Let's now move forward to our military representative, Colonel Stacy Shackelford, the director of the Joint Trauma System, is on, and we'll talk a little bit about a case presentation from military experience. Colonel Shackelford.
Okay, good morning. Let me see.
Just need to see the slides, see your face, so we got some connection.
Hopefully
you go.
That will.
You see your email.
Get it up.
No email should be in there.
How about that?
if you open the PowerPoint, and then when you do the share, it'll have several options available. You should be able to click on the PowerPoint itself. There you go. You're ready to roll, ma'am.
Okay, right on. Dr. Rasmussen asked me to summarize the military experience here. So this is a little bit of an overview of our summary of experiences with REBOA from the trauma registry. So shown here, you'll see our clinical practice guideline. And my Siri is talking to me. And you can see we have a little bit of a separate algorithm for blunt and penetrating. And so in our registry currently, we have a total of 28 REBOA patients and 29 REBOA insertions. There was one casualty who was quite the unexpected survivor who had 2 REBOA insertions at both the roll 2 and then subsequently again at the roll 3. The first documented use for REBOA that we could find was February 2017. And I think the blue bars there kind of highlight the most common cases. So approximately 21 years of age, approximately 18 cases of our austere single surgeon forward position teams, and 18 of the cases transferred directly from the resuscitation team to a host nation facility and essentially had very little follow-up. The demographics of injury mirror our overall demographics of our mechanism for the trauma registry and the military environment. In this case, we had only one blunt motor vehicle crash for a REBOA insertion. The other ones were penetrating and blast. You can see for zone 1 inflations, there were 9 with a mean time of 22 minutes and a range of 12 to 45 minutes. And for zone 3, there were 11 inflations with a mean time of 34 minutes for the balloon and a range of 10 all the way up to 110 minutes. There were actually 5 where we didn't have the documentation of the zone of inflation. And here you can see the locations of injury for each zone that was inflated. So in green there is the zone 1 inflations were primarily abdomen. And then in zone 3, you can see there was also abdominal injuries found, as well as a prevalence of pelvic and lower extremity injuries. And then another thing that we track for our performance adherence measures, this is the metrics that are included in our clinical practice guidelines. So you can see there the chest was evaluated for contraindications, signs of hemorrhagic shock, the FAST results were documented, the REBOA applications were reported to JTS, and all complications were documented. So here, the chest was evaluated. This could be by chest tube, chest x-ray, or ultrasound. And in 17 cases, that was actually documented. There was one case where the chest was noted to be positive, and REBOA was still performed, and 9 cases where it was undocumented. Next, going on with the region of injury and positive FAST results, you can see here that there were cases of chest injury, as well as, you can see it in the 3 and the 4 there, as well as to the right upper quadrant of the abdomen, 1 to the left upper quadrant, 1 to the peritoneum and pelvis. These are the indicators for shock in this series of 28 patients, and you can see the blood pressure averaging about 90, the range of the base excess and pH, the heart rate averaging in the low 100s up to 120, and then the hemoglobin there shown there with the lactate. So they were pretty severe signs of shock in this group of casualties. There were 5 deaths 2 cases where infection was recorded, 2 cases of extremity embolism, 2 cases of pulmonary embolism, 2 cases of acute kidney injury, and 1 case of a patch angioplasty. And of note, there were 18 of the 28 cases had no follow-up. So those are essentially the complications that occurred in the other 10. And then 1 case of mechanical balloon rupture that wasn't fully documented, but it had ruptured and noted to be ruptured at the time of balloon removal with no untoward patient outcome for that. And with that, that summarizes our recent military experience. Again, very useful in the most austere environments, and highlighting just the way that that's been utilized in the military.
Colonel Shackelford, with Dr. V's permission, I have a question here. So we talked a little bit about with the UK London ambulance, their PI process, but that's a little less challenging when you can get everybody in the same room. How do you facilitate looking critically at this experience and learning the individual lessons from utilization across this massive spectrum of people, where some of your data from the pre-hospital environment, people are literally getting shot at and are not going to stop and fill out, you know, the real-time information. How do you organize that PI process to learn and more effectively hone the indications for utilization for Ebola?
So we actually have 2 levels of PI, and we're trying to build up our automated PI a little bit more, but there some of the metrics that we've established can be measured fairly easily with just data points that are in the registry. So that would be the first level of PI. And that should highlight some charts for a little bit more detailed PI. For instance, you noted that there were some patients who had bleeding in the chest and still got a Reboa. That might make you think, you know, that needs to be a more detailed review. And so that chart will be pulled for a more detailed review. And then for our most detailed level of review, we do have our cases that are presented on our weekly Combat Casualty Care Conference, which is going on 15 years now. And when those cases are presented, they're looked at in the highest level of detail for every CPG metrics, as well as just decision making that is outside of the CPGs. And so that is a forum where we can really discuss. And it actually is pretty unusual. You know, I've been thinking we should totally do this in San Antonio. I mean, there's no reason why we couldn't get a phone call together with our pre-hospital providers and our en route care transport teams, et cetera, but we just don't do it. So it is kind of a unique opportunity for the military.
Unique challenges, and we salute you for everything you're doing in that regard. For the sake of time, because I think we're right on time, we're getting maybe 15 seconds over. Let's introduce Commander, is it Commander Brian Knipp? Yes. Commander Brian Knipp, U.S. Navy, who is also a vascular and dual vascular trauma trained surgeon, presently at Portsmouth, but en route to join the military trauma training program at LA County, as I understand it. So, Brian, you want to present our case, your case?
Absolutely. Thank you very much, Joe. I'm going to share my screen here. All right. Okay, is everybody seeing my slides?
We do.
Yep.
All right. So, good morning, everybody. I'd like to thank Dr. Veith, Dr. DeBose, the VEITH Symposium, and the Endovascular Trauma Management Society for the opportunity to present this case. So, I'm going to be presenting a case of, oops, sorry about that. Got multiple technology going here. So we have a 33-year-old service member who sustained multiple gunshot wounds to the abdomen, bilateral high thighs, right upper extremity, and the right chest. Per report of the on-scene medic, he initially collapsed after his injury, but he regained consciousness following initial blood product resuscitation. He got to our damage control surgical team 17 minutes after time of injury in profound shock, but with a GCS of 15. During induction, a 7 French sheath was placed under ultrasound guidance in the right common femoral artery, and a Reboa catheter was placed in zone 1. Central venous catheter was placed in the right common femoral vein. Bilateral chest tubes were placed, and no blood return was noted from either tube. At that point, the patient became severely hypotensive with induction of anesthesia, so we inflated the Reboa catheter to 8 cc's at that So this is a rough sketch of the location of the patient's penetrating injuries on arrival that I kind of did from my own short-term memory a day or so later. Patient underwent an exploratory laparotomy, which identified injuries to the dome of the liver, as well as multiple segments of small bowel. Mesenteric bleeders were suture ligated, and any clearly non-viable small bowel was resected. The patient was stabilized, and the Reboa catheter was successfully deflated. We put a temporary abdominal dressing in place, and a central venous line was then put in the right internal jugular vein under ultrasound guidance. We transferred our blood product resuscitation line to the jugular line at that point. While we were waiting for transport, the patient became hypertensive again, which led to reinflation of the Reboa catheter and a repeat exploration. We found additional mesenteric bleeders, and those vessels were controlled with suture ligation. The Reboa catheter was successfully deflated a second time, and the patient maintained normal tension. He had about 38 minutes altogether between the two inflations. The abdominal dressing was replaced, and the patient was transported to the Roll 3 facility. At this point, his total blood products were 37 units of blood, and 26 of which were drawn from a walking blood bank. The patient was then transported to the Roll 3 via a fixed-wing aircraft with the surgical team in attendance. The sheath in the Reboa catheter had been left in place in case the patient became unstable during transport, but he maintained hemodynamic stability throughout the flight with no ongoing blood product resuscitation or pressor use. Upon arrival at the Roll 3 hospital, however, the patient became hemodynamically unstable again, and he was taken emergently to the operating room for further exploration. Repeat XLAP demonstrated severe damage to the bilateral iliac venous system. The right common femoral vein was successfully repaired with a longitudinal venorrhea, and then we used the Reboa catheter passed up the right iliac vein into the inferior vena cava, as well as an 8 French Fogarty catheter placed in the left common femoral vein to decrease the hemorrhage from the damaged left iliac venous system. With this maneuver, we were able to ligate the damaged vein, and after plugging a hole in the perivertebral lumbar plexus with a gel foam tampon, we achieved hemostasis. At this point, the patient had gotten an additional 130 units of blood products, including 26 additional fresh whole blood units from a second walking blood bank that had been established at the Roll 3. We closed his abdomen again with a temporary dressing. We performed a left lower extremity fasciotomy given the venous outflow obstruction, and the patient went to the ICU off of all vasoactive medications. This is another rough sketch of the injury pattern, which is the primary source of the hemorrhage. And it was honestly pretty remarkable to me that there was no arterial component to this injury. And you can see from this pelvis film taken upon arrival to the Roll 3 emergency department that the bullet fragment burden was pretty substantial in this injury pattern. On post-op day 1, the patient returned to the operating room for further washout. No further hemorrhage was encountered. Following an angiogram, which is shown here, which demonstrated that the extremity vasculature was widely patent, the sheath was removed. His wounds were washed out, and the patient was then evacuated from the theater. He's currently recovering following multiple additional surgeries, and he's making good progress. So I took 3 significant lessons away from this case. First was that insertion of an arterial sheath early in the resuscitation pathway, based on the initial presentation and the mechanism of injury, permitted rapid deployment of proximal vascular control when the patient became hemodynamically unstable, prior to losing vital signs. Second, I would argue that while injudicious application of early arterial access might lead to an increase in access site complications, there's a trade-off value in the development of motor skills to safely and rapidly establish vascular access in an emergency. Similar to carotid shunting as a routine part of surgical endarterectomy, the regular use of this skill, while exposing some patients to increased risk, will also lend the practitioner improved capability, which is going to lead to decreased risk in more severe cases. And where this break-even point lies between the extremes of everybody gets arterial access versus nobody gets it until they crash is a matter of debate and might be worth studying. And then third, recognizing the limitations of a truly austere damage control environment is paramount. Good enough is good enough. The patient can then survive the transport to the next level of care. It's very difficult as a surgeon to leave rocks unturned, but if you're not in a position to manage the particular problem, then you need to attempt to temporize it only. So I'd like to thank you for the opportunity to present this case, and if anyone has any questions, I'd be happy to take them.
Well, Brian, that was a fantastic presentation and a really great save. I'm convinced of the value of Reboa after seeing that. One question, and I guess this applies to all the speakers and so forth. What do you do about anticoagulation? I mean, you've got a sheath and a balloon that's being blown up. What about clotting, and what about management of heparinization? You just not worry about it because they're bleeding so much, or what?
So there was an interesting article several years ago that Dr. Fox had written about anticoagulation in the trauma patient and management of vascular repairs. And his point was, fix the injury, fix it well, and don't rely on coagulopathy to get the patient out of trouble. I would say, I think the nature of the trauma coagulopathy kind of does the job for you. If you have the opportunity to, do local heparinization, heparin flushes, then you certainly should think about that. But in these really austere environments, I think it's just something you have to maintain a high level of suspicion for. My colleague, Dr. DeBose, he was, after discussion with him, is why we thought to do an angiogram before pulling the sheath, because those very problems can raise their head when you're dealing with young, healthy arteries in spasm, where a 7 French sheath in an older artery is going to not be occlusive. In a young, healthy trauma patient, it might be totally occlusive. So I think, Dr. Veith, your point's well taken, sir.
But if you had any problems with clotting?
Well, I'll tell you, Dr. Veith, I'll jump in here from the aorta registry. Essentially, the risk of distal thromboembolism is higher, but we've not had the limb losses that the Japanese have seen, and we've not seen any of the major kind of aortic thrombotic complications or showering. And I think we're helped out a little bit by the trauma pathology itself. Most of these patients are coagulopathic at baseline, particularly the ones that require a REBOA. And interestingly, when you look at even using the Prove It registry, looking at interposition saphenous vein graft repairs, intraoperative heparin doesn't really play a role in thrombosis or complication rates relative to those repairs. Some of that has to do with the patient's coagulopathy, and others have to do with, I think, a lot of trauma surgeons for both open and endovascular repair. We have a liberal utilization of that regional hep saline fusion, constant flushing of the sheaths with heparinized saline. If you're doing an interposition repair, proximal distal infusion, so that local utilization seems to help out some. I think Dr. Verjani has a question, if we can give him as part as we transition now into the roundtable discussion. Is that okay, Dr. Veith?
You bet.
Dr. Verjani, what do you have to say?
Yeah, Dr. Knipp, great case. And I would use it to highlight an important concept. And we talk about keeping people alive, and that's fantastic. And we fix the problem. But he has a ligated iliac vein. And I think the next step for societies like this, as we think about endovascular trauma management and trauma management in general, is what does that look like for him long term? Right. And so I don't think we have great data on what it means to have a long-term venous injury or ligation. I've seen some data that the most common PAMA procedures that are done nowadays are actually following major trauma and ligation of an iliac vein. And I would encourage us all, as we continue to accumulate this data, to really continually focus on what does long-term functional ability of the limb look like, particularly after major venous trauma, because his story is not over. And I think we've all met these patients 20 years from now, and it's very debilitating for them.
Yeah, great question. We have so much to learn, I think, in terms of the long-term follow-up relative to vascular injury. I hope the Prove It registry and some of the VQI initiatives will help with some of that. We've now kind of turned the spotlight on trauma a little bit more. And a lot of that, we honestly have to thank Dr. Veith for raising the awareness through his availability of these kind of talks like this, and his own meeting to have some time to raise awareness and find some kindred spirits relative to trauma vascular outcomes. Dr. Veith, do you have any other questions? I think we have about 2 minutes left. Do you have any other questions for any of the panelists?
Yeah, I mean, I think this has been a great session. I've learned a lot. I'm sure everybody who's on it has learned a lot. Hopefully people will go on and look at the recorded session. I'd like to congratulate Dr. Hoare and you for putting it together, and we're just lucky to be able to participate with you. Great session. Look forward to the next one.
Fantastic. Well, Dr. Hoare, I hate to end anything early, but in the absence of any other questions in the question panel, we've had some great discussions on the sidelines here. And again, if you have any that you think of afterwards, please reach out to the moderators, panelists. We can certainly facilitate making connections and furthering this discussion. Dr. Hoare?
First, I would like to thank Dr. Veith and the VEITH Symposium, and Dr. DuBose, Dr. Rasmussen, and all of you for taking part of it. This was a great chance to discover new things and discuss, and I think it's a lot of unexplored area that should be incorporated in vascular congresses and in other meetings. I just want to say several things. First, I want to thank, we have some partners here that helped us to get this going and doing it in a special studio format. And we would like to do it more longer, but it's a bit hard. And we will try to be online. We are online now, and we will have it recorded on YouTube and other channels. And the most important thing to thank you, the panelists, and again, the VEITH Symposium for doing this. And we will be back on Thursday next week with Dr. Asher and Rasmussen, and we will continue these activities. So thanks a lot.
Nice to see you all. Stay safe.
Thank you.
Bye.
Bye.
Thank you.
Thank you all.